when we look insecure housing, we looked at social lifestyle, and we collect a lot of this data because as part of routine HIV care, we asked, Bud, how much illegal drugs have you done? Smoking? Have you been in jail? What's your housing situation? We also ask, are you married, you've got kids, you've got employment. We collect a whole lot of social factors. And we found that for both women and gay males, there was a strong association between IPV and insecure housing, incarceration, illegal drug use, and actually cigarette smoking, that of that crowd's probably the least damaging option. So IPV in the HIV population associated with all of these factors, which probably doesn't, it's common sense, but it's nice to actually show it. We found that IPV was, surprise, surprise, associated with being depressed. Anxiety disorder, I wonder why. If you're scared you're going to get beaten up when you go home, no wonder you've got anxiety. And a huge association with suicide attempts in our women. So it's a really bad medical marker for my patients that receive regularly for their traditional medical care doing badly from the other angles. It has an impact on quality of life, which doesn't surprise us. Now, I work with an anthropologist who keeps telling me, well, but what's this really mean? How are you going to sell it? John, the governments will say, well, bad things happen to people. You know, we've got programs in place for this and that. To get any resources or buzz or research grants, you've got to show that this really impacts something governments care about. What do they care about? Money. Got it. So there is a wealth of literature. If you interrupt your HIV care, your immunity deteriorates, and somehow you'll end up in hospital, you'll end up really sick, you might infect other people. And we know that interrupting HIV care eventually costs money. It may not cost money immediately because you'll probably be well for a year, but may infect someone, which will cost the government, or someone eventually, a lot of money. So money counts. And so keeping someone engaged in care is important. And IPV means that you're more likely to drop out of care or have detectable viral load. And detectable viral load is bad because you're infectious to others and your disease is probably progressing. So all the other bad things, yeah, well, we've got programs in place. But big ticket items, and it comes back to my $29 million drug budget, interrupted care, failure of therapy, and detectable viral load, money. So we think that's a useful angle to pursue, and they're still doing it. We also could show that people who've got IPV are more likely to be hospitalized, either for HIV or unrelated. Maybe they get beaten up, they're unrelated HIV hospitalizations. And presenting with AIDS. So if you're not, you've got IPV, you're at increased risk of bad medical outcomes with money. So why is it different in HIV? Well, if you're ignored, you infect others, it's bad for your health. It also exacerbates all the other things in the syndemic. If you have HIV, you are lower on the social screen. You may have your partner put you down. Your risk of IPV increases. Your risk of homelessness increases. So HIV makes other parts of the syndemic worse. It increases your infectivity. Now, what are we going to do about this? Well, syndemics mean that sometimes, as each feeds on each other, if you can take out one part of the block, you may actually collapse the whole circuit, and it may be helpful. Sometimes you may need to take out two parts. But knowing that IPV is a player in this syndemic leading to bad medical outcomes is really important. And HIV is unique because it keeps bringing patients back to me. If you don't have HIV, you don't see doctors. You can escape for 10, 15 years having a horrible life that's expensive and doing badly. HIV means if you're not on drugs, the disease brings you back to medical contact. And so it's different because the disease means you keep seeing someone who can actually hopefully intervene. What are the markers that we found? Well, as everyone in this room knows, it's a marker that you're IPV if you're homeless, insecure housing, illicit drug use, smoking, incarceration. It will be increased association with IPV, mental health issues, and poor medical outcomes. So, to summarize part one, IPV is syndemic with the other social determinants of poor HIV health. Drug use, homelessness, crime, alcoholism, poor quality of life. And in some patients, when you talk to the patients, it was the trigger for the whole cascade of terrible events. Now, this is not a cost of care issue. Even where we have free, amazing, potent, safe, well-tolerated antiviral therapy that will give any compliant patient a normal medical outcome, it's the social context that actually is going to determine whether someone does well. You know, I know in the United States you worry about cost of drugs. In my population, they're free. But we still have people failing, and it's not because the drugs are there, it's because of the social context. And that is an opportunity for everyone to address. If we don't recognize this issue, it will negate the money you spend on drugs directly or hospitalizations indirectly. So you'll leave the problem children out there infecting others and terrible for their own health. We need to address it. Now, in the bigger picture, I went upstairs 2 floors to get an IPV screen. There may be better screens out there. Maybe we need a better, more precise screen. I'm trying to work now how you characterize and quantitate IPV, because is it recurrent exposure? Is it one event of a really nasty characteristic that's so damaging? Let's get better grip on it so you can quantify it. And then we need better approaches for dealing with the long-term trauma of IPV and childhood abuse. I have great respect for my psychologists, my counseling team, whatever, but I'm not sure that they are really providing as much benefit as they or I would like. We need better interventions, which means you need a good baseline quantitate, characterize the IPV experience, and then look at different interventions to see what will really help getting someone out of that horrible syndemic. Anyway, if there are any, I'm not sure whether we've got any physicians here, but the thing to remember is when a patient, for whatever reason, is on therapy, they're infectious, the disease is progressing, and it will regress their costs, and it's part of medical care. I've come to realize this myself, the denial approach shouldn't work, should never be used. Well, I just look after their viral load. Someone else will look after their mental health, their social determinants of health. It's part of holistic care. It may not be adequately funded or recognized, but it really is part of being a physician. Okay, I'd like to thank my patients. They've taught me everything. You talk to them and actually they give you amazing history and you figure out what's going on. I've got a great team of social workers who all bought in on this. This wasn't done as a top-down, we need to do domestic violence screening, this is the research protocol, give me the thing and I'm going to make myself famous like trips to Albany, New York. No, we need to get after this group hug, we need to figure out what's going on because we all want to help our patients. A lot of this work was done by a resident of mine, Reed Siminia, who actually pulled the data together that we generated and helped write the papers, and a variety of other people with lots of expertise. Anyway, I'm on time. I welcome questions from the first part. And I'm going to make you work in the second part. Yes?
I just wanted to say that I think you have really paid tribute to the patient that you lost. You've done a lot of good work in her name.
Yeah, it hurt. is that when you lose a friend, that shouldn't have happened. Come on, I'm not going
I was curious about the language you use in your screening tool because I work for a domestic violence agency, and sometimes if you ask somebody, are you experiencing domestic violence, they don't recognize what they're going through as domestic violence. So I was curious how you word that.
Well, we've got it on the handout.
Okay.
Generally, we take a big breath and we say, this is common in our program, very bad thing. And these are the things that we consider as, and you give them, you keep talking. If you just, you need to give them enough options to kind of think about it. One of the things we're now going, as I'll talk about later, we're now going into asking people repeatedly for their patients to accept it. One of the happier things that I remember was we asked one lady, 4 months later, she walked into my clinic. My nurses told me that when I was last here, you asked me about domestic violence. And actually, it does apply to me from this point. That was wonderful. I had no trouble with her saying no, but she thought about it for 4 months and then introduced. That was telling me she interpreted, thought about it, and comes back. So that's, HIV gives you a chance to have repeated bites of the apple, which is really good to address something that's important. Whatever language works for you and you feel comfortable with. And there can be cultural differences. We do this in Newfoundland to Quebec to Texas. I'm sure they'll vary. Yep.
It's interesting. I was with a patient yesterday at the HIV clinic who I've seen over the course of 10 years, and she's out of care a lot. But what we talked about yesterday is that given her HIV status and her feelings of low self-worth and doesn't feel like she deserves much, she finds herself in relationships with batterers. And she talked yesterday about growing up in such abuse that she didn't even realize it was abuse. So when she finds a man that loves her unconditionally in her eyes, given her HIV status, she tolerates a lot. The other piece of what you're saying is that what brings her back to us is that she does need medical care, and we'd like to see her on meds, and we'd like to see her stay on meds, but we lose her in care. She's also got substance abuse issues, and it's like such, everything you said today really just capsulized all of what we talked about. Her childhood abuse, her HIV status, all of that turning into substance abuse to cope, and then finding men that seem like they love her, but yet they abuse her, and her feeling like that's just a normal part of life. So one of the things we talked about yesterday is that she's in a relationship with somebody who's got untreated mental health issues, and I'm asking her to see me more regularly so we can talk about that. And I'm thinking that that's probably encouraging to her, and it might be the link, but you just really capsulized everything her and I talked about yesterday. And so this is very good to be here today. And
glad I'm not the only one suffering from such difficult challenges.
yeah.
But I think of another lady that she could not swallow her HIV drug. She had CD4 less than 10. She looked relatively well. You think she'd danced on the edge of a cliff with 7 CD4s. She couldn't swallow her drugs. And I gave her rilpivirine. Well, rilpivirine, so small you can barely see it. It's small. Oh, I can't swallow it. I thought, well, but you were eating. Oh yeah, but swallow a Cheerio, but my drugs no. And eventually we kept talking about this, and it was the experience of abuse from the age of 2, dysfunctional, abusive relationships, and the HIV pills reminded her of what a shitty time she had. And it was the concept of the drug. And after about 10 months with no CD4s, eventually we got her into, well, just think of it as a vitamin sort of approach. Just take it because you do it every day for your health. This has nothing to do with anything else. This is you taking control of your life, not letting bad relationships and HIV control you. And we actually escaped with this lady, which was very lucky. But you just keep working at it, and some you'll win and some you'll lose. But it's tough medicine. But I like my team. I've got lovely people I refer to. Oh, this one's tough. Any other questions?
I have a question. I know you said that you have had 9 people that you kind of that day when they revealed they were out. Did you get people that revealed but weren't ready to leave, and then what?
If they're not ready to leave, they're not ready to leave, but we give them the option. I mean, sometimes it's when they really cough up the whole truth, they know. And you know, if they don't want to leave, they will make it sound less threatening than it may be. But boy, it's challenging. It's interesting you found out with your patient when you don't eat. Why they're not doing it just to make me irritated. You know, I've got to not personalize these things. Yep.
You mentioned one patient who you asked, you know, has anyone ever asked you this before? And he said no. Is that common to sort of for people to be like,
in
you
the
know?
last talk, I'll address this.
Okay.
I had a med student that basically we went and asked all our patients. Well, we asked 180 patients about what we should be doing, and we asked part of that survey. I asked you before about this. And some of my med students said, well, what do we teach in med school today? You know, I'm part of the curriculum, I have no idea what. Oh, we should ask absolutely everyone because we're told it's an important social determinant of health. It's really important. And I had a resident with me. You know, residents have done their med school training. They've been this girl's been in the trench for like 3 years. So he said, wow, that's really important. Now tell me, in your 3 years, how often have you actually seen someone asking this, you know? And yet, of course, I knew the answer. I mean, it was a loaded question. I've never seen it done. So our medical students are told, ask everyone, it's important. And in the trenches, oh, we don't ask about that. We're taught about it, we won't do it. Of the survey that we did, only 1 in 5 patients have been asked. We don't ask, well, don't ask, don't tell. You know.
No.
It's much easier to deal with, but it really doesn't address the underlying health problems. It's rather sad that everyone's scared to ask. And you know, we've got to get into the workshop. Why are we not very keen at doing that?
You mentioned when you first started to look at this whole issue that you knew you needed to take the next step and putting some resources in place so that if they said, yes, I'm in an abusive situation, are you going to address maybe later what those resources are? Are you partnering with other agencies? Or how are you just able to offer housing like that to those people that left?
The program budget that I have allows us to treat HIV, and that includes 3 social workers. We don't have in-house resources to do much ourselves. So we found who are our friends in the community. And there are, almost in every society, there are groups that are actually our friends that we need to find out who they are then. Because you have your safe housing for battered women, you have your needle use rehab programs, you've got housing for the people who mental. There are resources that you've got your alcohol, addiction, substance use teams. And it's really important to find out who your friends are out there, the psychologists. And there are also funds in many societies, charitable funds that you can access to appropriate people that you can refer to. So we've got a long telephone list. We don't do much ourselves. We will in a crisis, because we're social workers, we're pretty good at this, but we try and outsource to where there is, and that's much better on their budget as well. They like our referrals because they've been worked up properly. Okay, should we move on or have a coffee? Or
Yeah, we can move on to the workshop. If anybody needs the restrooms, they're out the door and to the left.
Yeah, why don't we give let's give a 5-minute break.
Okay.